So sometimes people with learning disabilities can find it quite difficult to communicate verbally that something stressful is happening in their lives. So sometimes you might spot that somebody's starting to withdraw. You might notice that they're starting to regress in terms of their day-to-day skills. So they're not able to do as much as they used to be, which of course we would all think, oh gosh, is that dementia? Well, it might be, but actually because of the communication challenges and various other things, sometimes that can be a result of stress in the person's life that they're not able to communicate.
Good afternoon, everyone. Thanks for joining us once again at our Facebook Live session. Through this year, we've been covering various aspects of dementia, and today we're going to talk a lot about learning disability and the impact of dementia on someone who has a pre-existing diagnosis of learning disability. So, to some of you who may not be familiar with the term, learning disability is also known as intellectual disability. In simple terms, it means that people do have global intellectual disability, and it affects whole of someone's life. And in that sense, it's different from learning difficulty, which is just related to some parts of learning as such. We do know that people with learning disability are at a high risk of developing dementia as opposed to the general population, and therefore we felt that it was very important that we address some of the concerns that carers of someone who has learning disability and then goes on to have a diagnosis of dementia, they get to understand dementia and the kind of support that is available. So for that reasons, we have the pleasure of being joined by Dr. Elisabeth Goad, who is our guru on positive behavior support plan and has been with us in our previous sessions as well. She's kindly agreed to share her experience of working with people with learning disability in her clinical role, who then go on to have dementia, and then would be happy to answer questions that a lot of you might have. So, Lizzie, welcome back, and thank you once again for sharing your valuable time with us. For people who may not be familiar with you, would you mind introducing yourself, please?
I would. Thank you very much. So hi, everybody. My name's Dr. Lizzie Goad, and I'm the lead psychologist for the Learning Disability Division of our local NHS Trust. And a large part of what our team does is supporting people with learning disability to receive a diagnosis of dementia when that's appropriate and provide support on an ongoing basis after that. So it's a real pleasure to be talking with you today on a topic that is really, really important.
Thanks, Lucy. And there's a very first question as soon as we've started. Can a learning disability cause dementia? It's certainly a very significant risk factor for developing dementia in late life, and we'll be talking a lot about the risk factors, the symptoms through the course of this session, Sally. So we'll start as usual with a case vignette that helps us to understand in real terms. So, Lizzie, from your experience of working with people with learning disability and dementia, could you tell us your own experience of working with someone? Thank you.
Yes, of course. So I thought I'd pick somebody who's got Down syndrome just because that's where some of the risks are quite high for developing dementia later on in life. So to be specific, I worked with one particular gentleman who was about 65 years old, and his family started raising concerns about his memory, which seemed to be worsening. So as part of our trust, we have an initiative where we do baseline dementia assessments for people with Down syndrome when they're about 30 years old. So this gentleman had fortunately already had that. So we'd got this assessment done already when his brain functioning was at its very best. And that kind of included a thorough assessment of his adaptive and social functioning, which basically just means, what he's able to do on a day-to-day basis. And there was also a cognitive assessment there. So just something that helps us to assess memory, processing speed, spatial awareness, things like that. And he had several people in his life who knew him well across a range of settings. So that was really, really good in making sure we had a good understanding of what his baseline functioning was like. So that meant that in the present time, I was able to check in and request some various physical health assessments from the GP, which we always like to do first to make sure there's no physical cause for a change in the person's functioning and their memory. And then we were able to repeat the same assessment that he'd had kind of all of those years ago. And that enabled us to have a
Mm,
look at whether there had been a significant deterioration in his, cognitive functioning, so his memory in this case, but also his, day-to-day skills and how he was managing. And from there, we could see that there was a significant deterioration. So we were able to make a diagnosis of dementia. And that's kind of just the beginning of the journey. So there's obviously that diagnosis, but then thinking about, although dementia is not curable, there's an awful lot we can do to think about quality of life. So working with him and his family to think about how we could make his environment much more dementia friendly, trying to think about supporting the family to do some life story work
mm,
with this gentleman. So that's just a way of sort of drawing together important parts of the person's history and bringing that into the present. And the reason that's
mm,
as important is because people often start feeling like they're losing a sense of their own identity when they receive that diagnosis of dementia and when things start changing for them. So it can be really, really good, particularly because people often start struggling with their short-term memory
true.
first, but they hold their long-term memory for much longer. So if we're kind of working with long-term memories, bringing them into the present to help support that sense of identity and well-being, then it's really helpful in terms of keeping people feeling well and feeling like themselves for a long time. So a bit of a
Mm.
simplified version, but hopefully that just gives a little bit of a sense of somebody and some of the things that we can do to support people.
Yeah, absolutely, Lucy. I think it's good to have that idea that someone starts with Down syndrome and learning disability. You do a baseline assessment, and therefore you've got something to compare to, and you
Yeah.
draw in a rich source of information from people who know this person, and therefore you're able to make that degree of reliable assessment and diagnosis in terms of dementia. And it looks like from what you've said so far, the circumstances of care, the people involved in care for someone with learning disability who then goes on to develop a dementia could be very different from someone who hasn't got that learning disability and then gets an age-related dementia later on in life. So could you tell us more about what kind of differences you might actually see in their circumstances, and how it's important to take that into account?
Yeah, absolutely. I think although there are some similarities too, of course, I think there are important differences. And I think, yeah, one of the main things is that somebody with a learning disability who then goes on to develop dementia compared to somebody in general population is that they obviously already have those pre-existing cognitive challenges. So their baseline is already very different to somebody in the general population where it's not potentially. And that's due to the nature of their disability. Learning disabilities, as you said at the beginning, there will always be a level of cognitive impairment. That's
Mm,
different for everybody, but it will always be there. And that means that they are already struggling in one way or another with their day-to-day skills, with their cognitive
mm,
ability. It has an impact on their life. So they're starting from a much lower baseline than somebody in the mainstream population might well be. So I think that's an important thing to say. Um, and the result of that can be that sometimes people are already receiving some kind of care and support. Not
mm,
always, people with learning disabilities do live independently too, of course. But lots of people do receive care and support, and that's often from family, or it might be that they're in some supported living or some kind of care setting that gives them that support to help with some of those challenges. So we might be looking to sort of try and extend that support or thinking about how do we make that more dementia specific. Whilst people in mainstream population obviously are often living independent lives, they're supporting themselves and their day-to-day life really well. So the onset of dementia can be quite a difference in terms of what support and care that they need. Yeah, and I think the other thing is just that the kind of onset can be different in those general populations. Of course, we do have early onset dementia, so it's not that that can't happen. But generally speaking, the onset of the disease is much later, um,
mm, true.
in mainstream populations, and for people with learning disabilities, particularly those with Down syndrome, where it is much of a higher risk factor, we tend to see people starting to struggle or starting to receive a diagnosis a lot earlier on than in our general population. So I think that's probably another difference as well.
So it does look like so you need to take into account some of the pre-existing cognitive challenges that someone might have on the background of learning disability, and also that they might have some degree of care needs already, and therefore it's a question of trying to see what has actually changed, and they might be plugged into some care support systems that might be very useful.
Yeah.
that's useful too. And I think it's very important that you raise the point that people might get a diagnosis of dementia much earlier in their lives compared to some of the people in general population who may
Mm.
get it later on in their life. So those are very important points in terms of how dementia presents in learning disability population. What kind of symptoms, or what should carers or family members of someone with learning disability notice in terms of thinking, well, there is a change, and is this a dementia? What kind of symptoms will they have to look out for?
Yeah, that's a really good question, actually, because there are obviously lots of similarities, but there are some subtle differences as well that's important to be aware of.
Hmm.
Um, so if we take Alzheimer's, for example, we do often see with people with learning disabilities that sort of apathy, so kind of feeling quite flat in their mood for a long period of time that's not usual for them. And that can sometimes come first, although not always. And
Hmm.
we tend to see sort of relatively early on those changes in memory, and people starting to forget people's faces or names, or word finding difficulties, things like that. And
Yeah.
then moving into the kind of disorientation and confusion, getting lost more easily, and also the depth perception issues where you might suddenly notice that your loved one is, struggling over going over dark flooring or mats, or they're finding it difficult to go downstairs or over curbs, things like that. Just they feel a bit uncertain, like suddenly they're not quite sure where the bottom is. So we do definitely see that, and that's not different from the general population. But I think one thing to kind of note is that because in Down syndrome, where the risk of developing dementia is higher, and is higher than general learning disability, but obviously a lot higher than general population. But we
Mm.
sometimes can see with that specific group of people that the first presentation is a little bit more in line with more of a frontal lobe type dementia. So what that means is that we see a little bit more of changes with mood. We often see behaviour that challenges, that suddenly feel very confusing to carers, what on earth's happening, personality changes, and difficulties in what we would call executive function. So thinking about how the person is able to plan and solve solve problems, how they're able to reason, initiate activity, that kind of thing. So sometimes we will see that part first, and then it'll move into the memory problems and that sort of thing slightly later. So it can look a little bit different, I think, from that point of view. But I think the key thing with learning disabilities to be aware of is that some of these signs and symptoms can actually be caused by other things. Um, regress in terms of their day-to-day skills. So they're not able to do as much as they used to be, which of course we would all
Mm.
think, oh gosh, is that dementia? Well, it might be, but
Mm.
actually because of the communication challenges and various other things, sometimes that can be a result of a stress in the person's life that they're not able to communicate. And the same can happen with behaviour that feels challenging to us. So again, you might kind of see lots of behaviors which is often related to distress but come across as difficult for people around them, and that can relate to triggers in the environment, but they can't necessarily communicate about what's happening, so they tend to communicate through their behavior.
Mm.
So it's important to be aware of that, because one of the first things we always say to people is just have a think about that person's whole life. Are there
Yeah.
changes that have happened, things going on, triggers that might be causing some of those things? Because what we try and do is eliminate all of that before we then go on and think about that dementia diagnosis. And then, yeah, physical problems, again, that can happen for both groups of people, but it is important because in people with learning disabilities, it's quite common, unfortunately, that physical health problems are missed. And there's
Mm.
lots of different reasons for that. Sometimes people just put behavior down to the fact they've got a learning disability, or the person's not able to communicate the symptoms of their physical health problem, so it's not seen. And actually something quite simple like a UTI could
Mm.
mean that somebody gets really confused,
Mm.
and it's nothing to do with dementia. It's that there's a physical problem that needs to be solved. So I think it's just important to can be aware of that, really, because I think the first thing I would say is when you're thinking about signs and symptoms, just have a think about the person's environment, what stresses they're going through, and potentially suggest that they go to the GP for that general health check, just to make sure there's nothing obvious physical going on that could be accounting for any of those symptoms. And if all of that's sorted, then can kind of look at that dementia diagnosis and whether that's a possibility or not.
Exactly, because dementia is a very life-changing diagnosis to be offered and shouldn't be
Yeah,
offered in a very light sense. So what you've said to us is that rule out any stressful situations, rule out physical health issues, and if there is still persistent change of mood or behavior or personality change or memory problems, then yes, absolutely go ahead with having that call to GP to try and
yeah,
make sure that an emerging cognitive impairment is not missed.
definitely.
So that's very important for us to understand in the context of pre-existing learning disability. One of the things that you've said so far in terms of risk factors for developing dementia, Lizzie, is having Down syndrome,
Yeah,
and which kind of goes in with Sally asking us, can a learning disability cause dementia? So it does look like there are certain risk factors which could increase the risk of dementia in someone who has a pre-existing learning disability, one of those being Down syndrome. What could be the other potential risk factors for developing dementia in this population of people?
yeah, it's a good question from Sally as well, because it doesn't learning disability doesn't directly cause dementia, but as you said, there are risk factors associated with it that can increase the likelihood of having it. So that's definitely really important. Um, but in terms of specific risk factors for people with learning disabilities, as you say, Down syndrome is one. There's not loads of research into other conditions that are related to learning disability that tell us what the prevalence rates are there, but Down syndrome is one we definitely know is quite high. General learning disability, where there's not a known cause for it, is also higher than the mainstream population, but it's not quite as high as those with Down syndrome. And other things tend to be around, poorer physical and mental health throughout the person's life is a risk factor, particularly where there are undiagnosed health problems. And one of the other things is around the severity of the learning disability. So people with mild learning disability that isn't related to Down syndrome, they actually aren't too far off the prevalence rate within the general population. But if we're thinking about severe and profound learning disabilities, then the risk is much higher in terms of developing dementia for those people. And of course, the risk factors for dementia in the general population is also relevant for this group too. So things like age, poor diet and exercise, cardiovascular risk factors is a really big one. Poor engagement in education. So even though people with learning disabilities, there's lots of thinking around because they haven't got the same level of cognitive reserve that other people have got, that might well contribute. But it's still important in terms of for them, gaining an education within their own ability,
Mm,
because the less they
yes.
do, then the more likely they are
Yeah.
to receive that diagnosis later in life. So that's really important as well. And then, social activities and employment, head injuries, things like that. So all of the normal ones, as well as those specific learning disability ones as well.
So it's about the severity of the learning disability itself, the physical health, the mental health complications one could have,
Yeah.
alongside the general risk factors for dementia in a population that would all increase the risk of dementia in a learning disability setting. Um, and I'm going to ask this question because we do have a question that's come up. So so people have thought about cognitive impairment as a carer, and what is it that they would have to expect as part of a diagnostic workout for someone who has a learning disability? Because the question is more about
Mm.
uh, should they have a brain scan? If so, when? Why? What's the point of it? So that's the question that's come up. So what involves the diagnostic workup in someone who has an LD?
Okay, so I'll take that question in two parts then. So the first bit, and then I'll take the brain scan bit, because that's quite a common question I think people kind of wonder about. So that's a good one to
Mm,
ask. So what would you expect? So you'd expect a specialist service to make sure that the person's had that proper health check at the GP. So checking things like sight, hearing, blood pressure, heart, also doing some basic blood work to make sure there's no obvious physical cause for their symptoms. And then what you would expect is that service to do some specialist interviews and using specialist questionnaires that you would generally do with a range of people who know that person well to help understand their day-to-day functioning.
mm,
Um, so if the person is able to contribute to this, then obviously that's really important that they're also involved in it. But otherwise, then you can do it with family and carers and things like that as well. And that means that we can see whether the person's function has deteriorated across all settings or whether it's just across one. So that's important in terms of us trying to understand what's going on. We also look at wider mental health and trauma and whether there are other things that might be able to explain what's happening that aren't dementia. And then with as many people as possible, we'd also expect to see a cognitive assessment done. And those are different from what we'd see in mainstream, that they're adapted, but it's not always possible to do that with somebody with that severe disability. So the qualitative information from family and carers is really crucial in making that diagnosis. And then what we'd often do, if we haven't got a baseline assessment already, we'd often repeat that assessment 6 months to a year later, because then we've got the comparison and we can see how somebody's changed. And that links to the scans really, because in the mainstream population, we often have scans to look at what's happening in that person's brain, and we can see whether that's different from what we would expect to see for somebody of that age. But for people with learning disability, there's not really a standard kind of brain that we would see, because we can't compare results in the same way, because people with learning disabilities brains look different to each other. There's not a set way of them being. So we might ask for a scan and see some atrophy or something on the scan, but actually that might just be normal for them. So scans don't generally help in the same way. But we do ask for them occasionally, and that's usually if there's a concern about a vascular risk. So maybe we're worried somebody's had a stroke, or that there's something like that that we can see on a scan and is helpful to know about. But generally speaking, we don't use scans in quite the same way.
Okay, so we do a full screen of physical health, but what it comes down to is that very rich qualitative information that you could get from family and carers about the change, the duration of the change, and how it's impacting on someone's functioning ability. And then you have cognitive questionnaire, which is adapted from what would normally be done in a memory clinic, for example. And then scan is where there are particular vascular risk or things that you're particularly looking for, um, but not as a kind of a general guide, because
No.
the brains, as you said, are very different, and we can't go with the normative data in that sense. So I think it's very important that the focus is on that very rich qualitative information that family members and carers are able to provide. Um, I recently had a referral as a clinician myself for someone who had a learning disability, and they'd conducted a cognitive assessment using the kind of Adam Brooks cognitive examination that we use in the wider population. Unfortunately, the person had scored low, and then the question was about dementia as such. And but then you did mention that it's not a one-off assessment. So could you elaborate on, how do these kind of serial assessments work, Lizzie?
Yeah, absolutely. So we do, generally speaking, particularly for someone with Down syndrome, you do a baseline assessment when they're well, and then you would do another one when they start to get symptoms, if that's what happens. Um, so that's generally what we do with somebody with Down syndrome. If it's learning disability generally, we often do the first assessment at the point where they start to be concerns, and then we'll do a follow-up one. Could be 6 to 12 months later, but if they're deteriorating really quickly, then we bring it forward much quicker than that. But it just depends, because you need enough change to be able to make the diagnosis. Um, we used to do kind of serial ones where we'd be reassessing kind of regularly throughout the person's life after about age 40 for someone with Down syndrome. We don't tend to do that quite so much now, just because it's quite a lot to put somebody through, and often you get a bit of a variation in scores. It's not that helpful. So we try and just do a really thorough assessment to start with, and then later down the line, obviously do that second really thorough one, so that we can try and make a diagnosis as quickly as we can, just because it's better, from an ethical point of view for the person.
Yeah.
But we do occasionally, you can do a one-off assessment if there's enough change, but it's quite rare. Often we do need at least
Mm,
two, because we
mm,
don't have that normative data to go on. We're having to
yeah.
use the person's own norms, so go with what their baseline is from wherever we can get that, and then see what the deterioration is. So that's why we often have to do more than one.
So thanks, Lizzie. And I was going to say that that's quite a journey for the carer to go through.
Yeah.
They would have come to terms with the learning disability part of it, and then they notice a change, and then there's a series of assessments to go through. What and it might take an emotional toll on the carers. What would you tell them about the kind of support they need to look out for?
Yeah, definitely. I think it's really, really important to take time out to look after yourself and be open to kind of getting help where you're able to, if that works for you. Because I think if you're feeling really tired, then often your loved one will, be able to sense that in one way or the other, and that's really hard for both of you. And carer stress and burnout are real risks, and they become greater as the care command sort of increases as well. And my experience is that carers often find it really hard asking for help for themselves, because
Mm,
they
mm.
are really, really good at taking care of other people, but struggle a bit to think about them. But actually, you're the most important medicine that your loved one receives, so we need to take care of you as well. So just making sure you do get your own support, kind of emotionally if you need it, making use of dementia care charities like this one, to connect with other people going through something similar, and also just making sure that if you want to, that you're requesting a carer's assessment from your local authority, which you're absolutely entitled to. So definitely, just a big one around looking after you.
I think that's a very, very important point, that we are generally not very good at looking after ourselves in our carers role. And I kind of usually go to this situation where you're on an airplane, and then the pressure drops and you're the first person to put the mask on before you put the mask on your loved one. So that's the principle to be used. And I really loved it to have you captured in saying that you're the most important medicine your loved one receives. So that's
Yeah.
very important for all of us to think about. And in terms of carers assessment, that's very important. And I would like to stress that if you're struggling with getting carers assessment, please get in touch with us using our carer support line, and we would be very happy to liaise with mental health services, learning disability services, social care in trying to get that organized. We're nearly close to the finish in terms of our session. You've explained quite a lot of things to us, Lizzie, in terms of diagnosis, the looking at a big picture over a period of time. What kind of treatment options are there for people who have the dual diagnosis of learning disability and dementia? And I suppose there will be a lot of different range of interventions that are needed.
Yeah, absolutely. There are lots of different interventions. So, obviously outside of my area of expertise, and within learning disabilities, we still consider medication around kind of trying to slow down the progression of dementia. So that's just something to talk to your psychiatrist about, whether that's an option or not, because sometimes it is and sometimes it isn't, depending on what's happening for the person, stage of dementia and physical health, things like that. But although there's no cure for dementia, there are lots of interventions to support quality of life. So that's around environmental changes and support with that, doing life story work, as I mentioned earlier, developing positive behavioural plans, which I know we talked about on a previous session here, particularly if the person's got some behaviour that tends to be linked to distress. So that's a really good one to have a think about. And just generally, as dementia progresses, more broadly, people can have difficulties with eating and drinking that might need a speech and language therapist, or additional physical health issues that might need some more medical input. So just be sure to talk to your local learning disability team to see what can be offered, because there's often provision around supporting that development as it goes through, as it impacts people in all sorts of different ways. So just making sure we think about all of those different things, really.
Thanks, Lizzie. So it has to be comprehensive. It has to look at the possibility of medications, but equally, and more importantly, even that it has to look at the person, the individual, and
Yeah.
how to support the individual person and the carer. And I can't stress more in terms of saying to you, please go and look at our positive behavior support plan video, where Lizzie has explained in depth about what could be useful. We'll also be sharing some resources that Lizzie has kindly put together for us in the context of learning disability and dementia. It will be available on the chat function soon. Lizzie, thanks for explaining to us a lot about learning disability and dementia. To our carers, before I let Lizzie have her final words, do contact us if you do have any questions. Use our supportive resources that are available. Our next session, which will be the final session that I'll be hosting for this year, we'll be focusing on new and emerging treatments for dementia with expert Professor Raman Nilfarushan, who has been part of these new treatment trials and would be elaborating on them. So do join us. It's on the 12th of December. And on that note, Lizzie, your final word for our carers, please.
Oh, just to say thank you very much for having me and for listening to talk to us about something that's really, really important. I know it's quite a lot to take away, so it's good to think a bit more about it. But hopefully, some of the resources will help you with that. But yeah, I know, as I said before, people with carers for people with learning disabilities are often very, very good at looking after other people. But just to say, please look after yourselves too, and thank you very much.
Thanks, Lizzie. Thanks everyone for joining us today. And I'm going to leave with a message that you are you're the one whose most important medicine your loved one ever receives. Thanks everyone. Have a lovely afternoon. Take care. Bye bye.
Bye.